N6 is not the goal is happy patients, results exceed expectations. Why not trifocals? Because of the glare halos, because all these are concentric, they have concentric rings on the surface of the lens, of the optic, and you can have glare, this photic phenomenon, or can be very troublesome for the patient as well. The new necessity is also good intermediate vision. What is important is the intermediate vision. For example, the newspaper sales in Chennai have come down. What is the reason for that? Because the near point has receded from 35 to 60 centimeters. Many people are not reading the newspaper from the newspaper. They are reading on the newspaper on the tab or the iPad as well. So I think the two examples I give you, the music master Ilayaraja and Kapil Dev. Ilayaraja operated way back in 2007. Now we put them on Restore Plus 4. At that time Restore Plus 4 was available. Now Ilayaraja is finding it difficult to use the harmonium or the keyboard. And Kapil Dev is finding it difficult to use the play golf because the intermediate vision is lacking. So the multifocal lenses are meant for housewives, house husbands and mother-in-laws. Okay, let's go through the, again you can see the new intermediate vision. Reading a newspaper in 2010, we used to read in 35 centimeters, but nowadays we are reading the newspaper in 2022. So what is important is the near vision or intermediate vision 50 or 60 centimeters from the eye. So again you can see the new generation IOLs, the IONs, the monofocal plus lens, the Impress and Swissfob. Every other company has got this lenses. EDOF lenses are also available, trifocals. I am not going through that as well. You can see this is the Technis lenses, as Partha rightly said. These are lenses, the time-tested lenses. They are the gold standard as far as lens technology is concerned. The IONs lens, what it does, it is in pure C, the modification of the optic is done on the posterior surface of the optic. Here the IONs is done, the modification of the optic is done on the anterior surface. So they combine with some spherical aberration which enhances the depth of the focus in these patients. So this Technis leverages a refractive technology, the IONs lenses. There is no rings. Because of the no rings, it works like a monofocal lens. There is no photic phenomenon. Only if you have rings, you will have photic phenomena. And again, there are no zones also, like the EDOF lenses also. Based on a continuous higher order aspheric surface, same base geometry as all other Technis one-piece lenses also. So you can see that central, in IONs lens, the center part of the optic, which you don't see. Under the microscope, you see just like a Technis lens, Technis one lens, it will be the same thing as well. The continuous power profile is created with a higher order A-sphere, which actually creates a very nice range of vision for these patients, and with less cost also. 1/5 of the cost of a pure C lens or a multifocal or a panoptics or a synergy lens for that matter. So it is only 25% or 20-25% more than the regular monofocal lenses for that matter. And that's the reason why the penetration of these IONs lenses or the monofocal plus lenses for that, the Swissfob again, I'm using a lot of them also from Appaswamy, it's very good. So you can see that improved intermediate vision, they don't mind occasional reading glasses. But if you make them micro monovision, for example, the first eye, I don't go by the dominant or the non-dominant eye. The first eye I aim for the emetropia, that is for distance. The second eye I aim for 0.5 to 0.75. That's called micro monovision or whatever it is. And because of that, the range of vision, because of the inherent quality of the lenses, it's able to give better vision, near vision also. The near vision will not be like a multifocal lens. Please understand. It's not like a trifocal lens. Near trifocal lens, you'll be able to read at 30 centimeters. In IONs lens, you'll not be able to at N6 at 30 centimeters. You'll have to keep it at 40 centimeters. But nowadays, 40, 50 centimeters, 60 centimeters are more required than 30 centimeters for that matter. So good distant vision, good intermediate vision, good near vision, good contrast sensitivity, no glare halos. The quality of vision is fantastic, just like a monofocal lens. Low cost, versatile. I can see this is the way, just like any other lenses being implanted. You can see it's like there's a beautiful injector. We call it the platinum injector, which goes through a 2.2 or a 2.4 millimeter incision also. This is just a study where you can see distant vision 20/20, intermediate vision, that is N6 at 50 centimeters, N8 at 40 centimeters. But to make them micro monovision, they are even N6 at about 35-40 centimeters as well. Just to happy Swissfob patient, golfer intermediate vision, IONs monofocal patient is able to drive in the streets like Andaman, wherein the roads are narrow. Impress monofocal patient, businessman. IONs monofocal patient, ophthalmologist from Russia. Again, IONs, my cousin who is a vascular surgeon in the US, is able to do the abdominal surgeries without any problem, he is able to drive, be able to play golf. For Rajinikanth, what is the rents? Okay? See, even if you have a problem in the posterior segment, he's got a eararm in one eye, so you don't want to put EDOF lens or a multifocal lens for that matter. So high-ans lenses work wonderfully well, even if there's a compromised optic nerve, a compromised macula, diabetic retinopathy, and all these patients also. My patients drive without glasses, high-ans patients drive without 96%, use a computer without glasses 95%, read a cell phone without glasses, which is very important in today's world, is 96%. So trifocal lenses and the monofocal plus lenses, whether you want this man, or Kamal Haasan, or Rajinikanth, or Sachin Tendulkar, or Dhoni, who hails from this Ranchi as well. Thank you very much for the wonderful opportunity, excellent visual acuity for distance and intermediate, good contrast sensitivity, no glare halos, Technis platform, which is a time-tested platform. Thank you again for the wonderful opportunity. Any doubts or questions I would like to answer. And especially for postgraduates, email to me at drmohanrajan@gmail.com. I'll send you 2 books, one on retina, another on cornea, which has got fantastic high-definition pictures as well. Thank you.
Thank you, sir. Thank you, Narayan, sir. Now I request Dr. Santosh Honavar, sir, for his talk on orbitotomy.
Thank God I went before Santosh Honavar. After Santosh Honavar, no, we'll all faint. Yes, because the level of science is so much high. Yeah.
Good afternoon. I'll be speaking on minimally invasive surgical approaches to the orbit. The current concept is less is more. Less is the intervention, much better are the results, fewer are the complications. These are many of the surgical approaches that we earlier used to do. In lateral orbitotomy, bone cut was conventional. Without bone cut, we wouldn't even start a lateral orbitotomy. That is how lateral orbitotomy used to be done in the era of Cronlean, 1888. It was an incision which was in the opposite axis as the orbit was. That huge flap was raised only to cut the lateral orbital bone and then get into the orbit. Currently we use eyelid crease incision, where an incision hugs around the eyelid crease with a small lateral extension, after which of course we tag the appropriate recti and then go ahead and do a skin incision, suborbicularis dissection to reach the orbital margin, and then everything else follows. More importantly, there is no bone cut currently that is required for a majority of conditions. You can see that with this approach we are readily at the orbital margin without much dissection. All this dissection is subcutaneous, suborbicularis. And then the exposure of the periosteum, everything else follows. But if you have a patient with a lacrimal gland tumor, then the incision is different. It is sub-row, because in lacrimal gland malignancies or suspected malignancies, if you do a lid crease incision, then it is very difficult to plan delivery of radiation. So once you have approached the tumor, everything else is generally the same. You open up the periorbita around the tumor. That is the horizontal limb of the T-shaped incision, vertical cut towards the orbital apex. Then you hold both the cut ends of the periorbita and pull in opposite direction. So you create a T-shaped incision and a V-shaped window through which you approach the tumor. Tumor is never held with a sharp instrument or forceps. The periosteum or periorbita is held and it is simply separated from the tumor. Wherever there is a vascular pedicle or a periosteal tag, then you bring in a bipolar forceps for dissection. Otherwise, you can see that most of the dissection is done with blunt instruments, creating a lamella. Now that is a periosteal tag there on the lateral aspect which needs to be cut. So you can use a scissors for that after guarding the tumor safely. That vascular pedicle of course needs to be cauterized to prevent bleeding. You need a dry field for you to visualize, otherwise surgery becomes complicated. You have to see everything that you cut. Then you ballot the tumor and see where else is it adherent. We knew from MRI that it was adherent to the superior rectus sheath. So we separated that. When the tumor is completely ballotable, you apply a cryopro for the anterior posterior traction and then assess what is adherent posteriorly. Under visualization, you have to separate these structures that are adherent posteriorly. Assessment is very important as to where could the resistance be. If there is no resistance, you simply support the tumor from the posterior aspect and deliver it. That is how we do without a bone cut. We can do what is called a marginotomy, which only means that you're taking off the abutting superiotemporal orbital margin. So this makes orbitotomy less morbid. Now this young lady has adenoid cystic carcinoma of the lacrimal gland. Look at the size of the tumor, but it is contraindicated to do a bone cut in adenoid cystic carcinoma of the lacrimal gland because that would provide it egress to the temporalis fossa. Such a large tumor can still be taken out without a bone cut. You can see from this video, periorbital dissection. Now we are cutting the septum because the tumor has involved both the palpebral lobe as well as the orbital lobe. We have to excise both the palpebral as well as the orbital lobe here and separate it from the lateral rectus muscle. Periosteal dissection on the temporal side. Guarding the tumor is very important. Don't ever hold the tumor with a tooth forceps. Gentle separation from the investing lateral rectus muscle sheath. Tumor is on both the sides of the lateral rectus. Once we are very sure that the muscle is completely separated, then you go behind the tumor and try to elevate it. The tumor starts ballotting completely and now you can see that it is getting posteriorly separated, all the while watching the pupil. This large size of a tumor can still be delivered without a bone cut. This is exactly what I'm trying to show here. So that makes the orbitotomy much less morbid. As you apply anteroposterior traction, the posterior adhesions become visible. Those need to be separated bimanually and sometimes with bipolar radiofrequency electrode, and the tumor is completely delivered. So lateral orbitotomy without a bone cut is in vogue. Now about most of the other orbital tumors can be approached by transconjunctival approaches. Only for the lateral and superior orbit you approach with lid crease incision or a subro incision, but the entire medial, inferior and extreme lateral orbitotomy can all be done with subconjunctival incision. This is a child with orbital teratoma where the tumor was on both the sides of the optic nerve. You can see a fully grown molar tooth right within the tumor indicating clinico-radiologically that it is teratoma. This was approached by the transconjunctival panoramic approach with lateral canthotomy and inferior cantholysis. Lateral cystic component of the tumor, that is the optic nerve which could be visualized under an operating microscope, and that is the medial solid component. And this groove was through which optic nerve was passing. And there's the same child after orbitotomy. You can see that all that is left is esotropia that needs to be resolved, disc edema resolved. This young lady has cavernous hemangioma of the orbit abutting on the optic nerve, and there again we use the transconjunctival orbitotomy. Simple approach I'm going to show in this video where you make a lateral canthotomy incision and an inferior cantholysis. That will open up the excess for the inferior fornix completely without any resistance. We have already tagged the inferior rectus muscle. That is the incision that we take running across the inferior fornix, just short of it, right from the lateral canthal angle to the base of the caruncle. Retract all the tissues, ledge the inferior orbital margin with a large spatula, dissect to expose the periosteum very close to the orbital margin, not to damage the infraorbital nerve at all. Periosteal incision very close to the orbital margin, then the periosteum is dissected until you reach one of the two endpoints, apex of the inferior orbital fissure or the infraorbital nerve, both of which being critical structures need to be well preserved. Once you reach these endpoints, you take time to cauterize the bleeding vessels. These are perforating vessels that are coming through the bone to feed the tumor. Every tumor, benign or malignant, is hungry for vascularity, and these are fed by these perforating vessels which need to be cauterized so that you keep the field dry. Then you make an incision in the periorbita, holding it up, dissect the fat around the tumor, retract it using retractors, all the while watching the pupil. That's very important. Dissect the tumor until it becomes ballotable. About 2/3 of the tumor surface is dissected before you approach it with a cryoprobe. Cryoprobe works like the third hand for the surgeon. It gives you a good anteroposterior traction, and you gently wriggle the tumor out with a lot of patience, always again while watching the pupil. As the tumor comes out, not to ignore the posterior vascular pedicle, which needs to be cauterized, otherwise there is a chance of secondary bleeding. That's it. So with this, what happens is that the patients recover very rapidly without any morbidity of large orbital surgery. Within a week, the patient would look like this without any external scar at all. And finally, the patient will have much less complications. In conclusion, I would say that well-planned, minimally interventional approach to orbit can help reduce morbidity and optimize the outcome without undue complications. Thank you so much.
Thank you, sir, for showing us those wonderful results with the surgery. Now I request Dr. M. Vanati ma'am for her talk on Phakic IOL Revisited.
Thank you, Jhoscon, for having me in this as part of a speaker in the AIOS session, and our apologies that we are speaking much later than our scheduled time here. I'm going to walk you through over the next 10 minutes on Phakic IOL and how we could probably perfect and our experience with a new Phakic IOL. No financial interest in the mention of anything during the course of my talk here. So Phakic IOL is a lens-based refractive procedure for correcting refractive errors for those corneas which are not amenable to laser correction, or if the correction required is going to be much beyond what is affordable even when the cornea is normal here. So that's going to be the basis when you understand the patient screening for offering refractive surgical correction using a lens-based procedure. That's the Phakic IOL procedure here. So just start with a case history of a patient. So 21-year-old female patient who reported with the history of best corrected visual acuity with a correction of -9.5 dioptric sphere in the right and -4.75 dioptric sphere in the left eye here, and she was 6'9" parts in the right and 6'9" in the left, and was a high myope here, and you could see that her posterior segments were also screened well for any other posterior segment pathology here, and that's the topography map here. Well, when her keratometry maps K1 and K2 seem to be okay, you could see there is a significant skewing in the right eye map, though the other parameters seem to be okay. And again, there is a significant skewing in the left eye map, though the thinnest pachymetry seems okay for this particular patient. We did take her up for a corvus also, and you could see the bad maps are deranged for this particular patient. And again, given the correction required of a -9.5, which means the residual bed thickness, stromal bed thickness is not going to be safe for this patient, using a lens-based refractive procedure here. And again, the percentage tissue correction also will be much beyond 40% in the right eye for this patient. All these made us offer her the Phakic refractive IOL for surgery for surgical removal of glasses in this particular patient here. So the gold standard of lenses followed, and with a large history, you do have the Evo Visian ICL here, which has a time-tested literature talking to it or about its safety in the patient's eyes here. And one of the newer entrants of the many, 2 or 3 which are now in the annual, is the ICRL Phakic IOL. The advantages of this being that it is a non-animal source here, and it is a little more rigid as compared to the more flexible and thin Visian ICL which we have here. And it also affords ease of surgery, that you can move it through a smaller incision compared to what you would need for an ICL surgery. So you can insert it through a 2.8 incision vis-a-vis a 3.2 which you would normally require for an ICL insertion of these cases here. It also gives you a wider range of power and optic diameter sizes when you are looking at correcting high myopias in our patients here. So these are these are the optic details or the geometric details of the phakic IOL here, with the periphery being slightly thicker, and that being attributed to a better memory of the lens to retain the lens vault in long term for these patients who undergo phakic IOL procedures here. We do have the phakic aspheric IOLs, and you have the phakic aspheric toric IOLs here for these patients. For want of time, I'm not going to go into the finer details here, and much of this is available when you refer to the particular website for the details on what are the ranges which you have on these patients here. So you have from a 12 to a 13.5 and 0.5 diopter steps in terms of the overall diameter of these lenses here, and you do have variable optic sizes as well of these lenses compared to the limited options which we have with ICL. Another added advantage is the cylinder placements of these lenses are such that placed at 0, 30, 60, 90, 120 and 150 here. So you place these lenses horizontally at 0, 180, and the amount of rotation you need to do for these lenses are much lesser vis-a-vis comparison of the ICL here. We did look at our data of over 100 eyes comparing the performance of ICRL to the time-tested ICL procedures in these patients over a comparable group of cases which were recruited here. Another advantage is that you do have an online calculator which does help you to also check the inventory, to check on the availability of the lenses and when these lenses can be available for our patients here. And this is how your calculation chart and the chart provided by the manufacturers appears, guiding you of how you need to place the lenses when you are planning such lenses here. I think another added advantage which this lens gives over ICL is that it also gives you the predicted vault in all these patients, the estimation of the predicted vault, and our data showed that the estimations which they give you helps us to look upon the size which would be optimal, especially when you are looking at outliers of patients, when you are looking at high axial myopia patients, where you know the correlation of the sulcus diameter estimation is not going to be as normal as you would see in eyes with a normal range of axial length between 22 and 24.5 here. So the axis marking is pretty much similar as you would need to do for your cataract surgery markings here, but the placement of the IOL is always 0, 180 degrees, and you would know that the axis placement of these lenses are custom made depending upon the ISIS, so there is minimal rotation that is required for these patients. A word of caution for those who are venturing to do phakic IOLs, your anterior segment OCT evaluations should be done for not only for anterior chamber depth and the endo ACDs here, specular counts here, but also look at the angle evaluations of these patients. The iridocorneal angles which are less than 30 degrees and plateau configurations of the irises are going to be a definite no if you're considering phakic IOLs of these patients here. When you look at them long term, there are changes in the angle opening distances for these patients, but our study showed that the ICRL is not inferior, and it's comparable to what you have in terms of results when you use the ICRL lenses. So this is one of the phakic ICRL lenses here. The cartridge is a Medisil cartridge, is one of the newer cartridges which gives you, and the ease of handling this cartridge is pretty much similar to that you would have for cataract surgery. The lens is taken out of its holder and placed with the convex side down here. So that is the difference in how you would load these lenses vis-a-vis how you would load an ICL here. And this gives you the same exact orientation which you'll have to look at the right leading and the left following has the optic holes here, but the lens is placed with a convex side down, and it is very much similar to how you would place them for intraocular lens loading for cataract surgery here. So that's how the cartridge is loaded, and you keep it ready for your patients, and then we'll just move on to close with the surgery of a phakic IOL. Can be done under topical anesthesia, but priming your patients well is very important, because especially if you're placing toric lenses here, you need them to be well dilated, you need them to be cooperating well here. So that will really help you to do an uneventful surgery in these patients here. That's the marking which is being done, and be careful that all your entry incisions, your blades is not facing the anterior capsule, but your blade is going parallel to the iris plane always, which avoids any inadvertent injury to the anterior capsule. The lens is placed, positioning it directing at the angle and not behind the iris, and then you would gently tuck behind the haptic plates behind the iris and place the lens in the position with minimal rotation required for best results here. If you do have the luxury of an intraoperative OCT, you can check the walls after you have removed complete viscoelastic removal or near complete viscoelastic removal to see the vaulting is optimal, especially in those eyes which are outliers in or high myopic surgeries here. I would stop here and thank you for your patient listening, and would seek your support for editor IJO 2026 to 2029. Thank you so much for your patient listening.
Thank you, ma'am. It's really a huge learning experience for us listening to you, all the masters. Unfortunately, Dr. Lalit Verma and Dr. Prashant Bhawankule had to leave to catch a flight, so we did miss their presentations. But it's really a huge benefit to all of us listening to you, masters. And it does help us in our day-to-day routine practice. And any word coming from you, masters, we do believe, and we there is something that we can. It helps us in our conviction, the way we talk to the patient, and the results that you have shown. Thank you very much, sir. And with that, we come to the end of this session. Now I request Dr. Vinita Ramnani to coordinate the next session, that is Sight Unseen, Contemporary Debates in Glaucoma Care. Okay, just before that,
Good evening, everyone. So we will be starting with glaucoma debates, and we want to make it very interactive. So request audience to participate, and I request the chairpersons to be there on the dais. Dr. B.N. Gupta, sir, please. Dr. Kirti Singh, Dr. J.S. Bhalla, Dr. Mayuri Bhattacharya. I request all the chairpersons to be there on dais, please. Sir Gupta, sir, aa jaiye, please. Dr. Bhalla, Dr. Mayuri, please come. May I request all the speakers to be in the front row so that we can save the time and get the debate discussed. So the first debate is on the upcoming thing, MIGS versus trabeculectomy in moderate glaucoma. So for the MIGS, I will be calling upon Dr. Anuradha Anindya, please.
Sorry, it's on, yeah. Good evening, everyone. Thank you, JHOS and delegates for giving this opportunity. So I believe I have just 3 minutes. I'll try my best to be quick. So MIGS is the future safe, smoother and smarter. This is the topic that's given to me. Well, glaucoma is the major cause of irreversible blindness. However, there is always an option to stop and halt there, depending on in which stage we are actually dealing with. Trabeculectomy being the gold standard, however, it does has its early and late complications, like early complications like hypertension, hypotony, and even late complication can go till endophthalmitis and bleib and cystic bleibs. So where comes the minimal invasive glaucoma surgery has a stand, especially in early to moderate glaucoma. We call it as minimal invasive because the minimal surgical steps are taken, the minimal conjunctival manipulation is done, and it's really takes a very less intra and post-operative complication chances are very extremely less. So why we call MIGS is smoother and smarter? Because it's a shorter operative time, minimal post-operative discomfort, and faster visual recovery. And also advanced microincision technique and effective and sustained IOP control can be combined with cataract surgery. So MIGS success rate comes to 45% to 90% and IOP reduction of 20 to 40%. The complications rate being 5 to 16% and maximum being, it's actually hyphema, but it's self-limiting. And rare serious events which is even less than 3%, whereas in trabeculectomy success rate is 77 to 88%, though the IOP reduction is higher, and the complication rate is also higher with a 20 to 50% high chance involving hypotony, bleib, and also choroidal detachment. So I'm just going to play the video here while doing the eye stent injection. So it's the prism. This is the eye prism, so light that hardly we have to hold it or press it, that the cornea folds are made. So that's why you can see there is no corneal folds at all. So I'm going for the first injection of the stent. So whenever we direct just the PT and ATM junction, actually we land up with the PTM junction. If we're directing directly to the Slem's canal, we may land up with scleral spur. So that's the first this in place, and you can see the iris coming out. It's a pseudophakic patient actually. So the ocular surface changes that can be very easily seen in this case. Sodium halonate is used, viscoelastic, thick, so that it can maintain the entry chamber for a longer time. Normally have less time, so I will like to complete my case here. Thank you.
Thank you, Anuradha. Now I invite Dr. Vinita Ramnani.
Good evening, everyone. I would like to thank JHOS for giving me this opportunity and Dr. Bharti for calling me here. And I will be talking about trabeculectomy. So it's a kind of a debate that in a moderate glaucoma, whether you will be doing an MIGS or trabeculectomy. So we know that trabeculectomy has many advantages, and we have been doing it from past 50 years. It has a longevity and it is very popular and effective in all the type of glaucoma, and it is proven acceptable safety, a safe incision option. But the disadvantages, yes, it has that risk of bleb failure and blebitis and sometimes endophthalmitis. So really, is it a bad option that we should be replacing it in MIGS in moderate glaucoma? If you consider the safety, efficacy and the cost, the trabeculectomy weighs much higher in Indian perspectives, because we don't know the exact positioning of MIGS in glaucoma treatment paradigm. So many MIGS techniques and devices, there is no consensus which technique is good. The results herself shared 45 to 90%, so it is so variable, and we don't have good data, the multicentric data to tell us that it is really good alternative of trabeculectomy in moderate glaucoma. Then beside this, there are so many hurdles. Not only it is expensive, but then learning curve is there. You have to learn intraoperative gonioscopy, you have to buy that gonioscope and position the patient. So leave behind the economy which is there in India, that expertise is also the skill of implanting so many different type of gadgets is really difficult sometimes. And it is not everybody's cup of tea. In the initial phases, you can create a lot of complications, especially the hyphema sometimes is very scary. And standalone MIGS, I don't think it has very good role. Most of the time, they do it with the cataract, especially for very early glaucomas. And then we have lot many contraindications. We cannot do it in angle closure, corneal opacity, neovascular glaucomas, and even the GAT, which is economical, is contraindicated on the patients which have a bleeding tendencies. So we have to rethink and decide in an era of MIGS, in a moderate glaucoma, will you do trabeculectomy or MIGS? I am in a favor of trabeculectomy because it is a good surgery. It fits in all cases, though it is high rewarding with a high improvement in the patients, and we don't have at this particular moment enough data to change our normal practice, which we have been doing it from 50 years, that we shift to MIGS. So which method to use, it's absolutely depending on the patient and the surgeon comfort. Both the methods has its own advantages and disadvantages, but being an MIGS, you have to do it in early cases. But then if you are confident of doing a trabeculectomy, nurturing your trabeculectomy blabs, I think you can go for trabeculectomy. And MIGS usually falls into the gaps between the medical treatment and aggressive glaucoma surgical treatment. Thank you so much for the patients listening, and I request you all to vote in support for member scientific committee. Thank you so much.
Thank you, Dr. Vinita. I do agree with you that filtering surgery has been there since long. I myself have been doing for last over 40 years filtering surgery. And so far as MIGS is concerned, I definitely agree that there is a long learning curve also. So Dr. Anuradha, can you throw some light? What about the learning curve for doing MIGS? Okay. Now the next topic is neuroprotection. So I will invite Dr. Poonam Singh. She is going to stay, neuroprotection is coming. I think it has already come. It was there since long. But of course, not an established fact.
A very good afternoon to all of you. So I'm here to do justice to my topic in 3 minutes and hold my fort on saying that neuroprotection is there, and it is not a hope. It is a hope, not a hype. So it is already there. Why so? Because we all know that glaucoma is a disease which is progressive disease of the retinal ganglion cell death, and it results in optic nerve head damage. So despite IOP reduction, there are 10 to 15% of the patients who still go blind. Therefore, neuroprotective measures are necessary because there is something beyond IOP control which is there and which needs to be treated. So this is a basic slide which tells about the details of that, how exactly the damage is happening at the axonal level. So basically high IOP is causing neurotropic deprivation. So what is neurotropins? Neurotropins are basically the growth factors which are required for the survival of neurons. Then if there is a ischemia, there is increase in glutamate, NMDA receptor activation occurs. With the activation, there is influx of lots of calcium influx, which will result in release of free radicals in the form and including nitric oxide, and finally retinal ganglion cell death occurs. All these neuroprotectors which are acting. These are acting at each level to reduce or stop the cascade which is happening in this whole process, so that the retinal ganglion cell death does not happen. So these are the basically therapeutic targets for the neuroprotection, like glutamate excitotoxicity, oxidative stress reduction, neurotropic factor modulation, and vascular and receptor targets to which regulate the calcium channels and nitric oxide synthesis. So ocular blood flow will increase and the ischemic and oxidative injuries will be reduced. So there are some neuroprotective agents which are already present, but there are certain trials which are going on which are in phase 2 and 3. So at present there are few neuroprotective agents which are going, but in the coming time there are already many studies which are going on, and we will have more gene therapies, like somebody gave a talk in the morning. So many new things are coming up in the near future. So something like nicotinamide and rho kinase inhibitor, genetic and molecular targeting molecules are there, and there are some already established pharmacological drugs which are there, and some are still investigational. Like we all know that brimonidine has a dual action because it lowers the IOP also, and mementamine causes neuroprotection. Citicoline is very these days being promoted, and nicotinamide, these are the some drugs which are available. So way forward is a holistic multimodal approach combining the IOP methods and with the neuroprotective. So both are important, but neuroprotection is also important, especially because it is progressive disease, and the combination therapies are components. Therapies will include pharmacological agents, neurotropic supplements, regenerative medicines, and advanced drug delivery systems. So personalized medical advances are also there. Some genetic improved biomarkers and genetic profilings, these are all things which are going on. So the successful treatment of glaucoma is not only IOP control but also neuroprotection and neuro restoration. So the in thing for a better tomorrow is neuroprotection. Thank you all. Thanks a lot.
Thanks, Dr. Poonam. Rightly you told that neuroprotection is still a debatable issue. It's still not established, but of course when we don't have
yes, definitely, sir, but the way the things are going, the main problem probably now is that when we will have it and how socially it will be available to the cost. There are so many things which are there still to be considered, but the point today to be proven was that it is the in thing.
By and large, it is a theoretical thing. So far as we
so
see
it is
practice.
theoretical because we are mainly targeting at major people whom we are targeting at IOP control, because that is one of the only risk factor which is treatable.
Right,
Whenever we talk about it, we say that IOP is the only risk factor which is treatable. So there are, and whenever we are counseling the patient for the first time, we always tell them there are n number of other factors which are still working, and so your glaucoma will progress. So there is the area where neuroprotectors will work.
Dr. Shalini Mohan, I think she is not here. So we go to the next topic. So since Dr. Bhalla has to leave, may I invite Dr. J.S. Bhalla for the next topic, to treat or not to treat. And Dr. Rashi Shyam is also there, yes. So Dr. Bhalla is in favor of treat early, prevent progression before it starts. It's already preloaded, I suppose.
Any question from audience till they load their presentation by the previous two debates? Anybody in a favor of neuroprotection and what exact neuroprotection they are using? Audience, please. Definitely, when you see disc pallar or if your IOP is not very high and if you are not very sure that it is just an high intraocular pressure glaucoma, probably you will switch more towards the brimonidine and orzolamide kind of a drugs just to take care of ocular perfusion as well as neuroprotection. And in such patients, I always go for a cardiac evaluation that they requires ECG, echo, carotid Doppler, and some patients may be in a multi-speciality where I am working, I go for an MRI also. So that will give you that whether they are progressing because of the systemic illnesses or because of the lower perfusion at optic nerve level. And sometimes you just give them B complex. It will increase the, reduces the ischemia and it will prevent the further progression of the field. Sometimes the fields progresses and then we think that we have to escalate the medication, but then the other factors like especially the B1, B6, B12, they are very important.
Yeah, I think this is important because if you have achieved target intraocular pressure and the patient is still progressing, then you have to talk of non-IOP related factors. And non-IOP related factor, because many of these, it is said that 30% of these open angle glaucoma patients have diabetes and 47% have hypertension. So
yes.
if the patient is also already on anti-hypertensive drugs and you find that the patient is progressing after achievement of target intraocular pressure, it makes sense to talk with the cardiologist or physician that patient should be shifted away from beta blocker drugs and to calcium channel blockers, because those are the drugs which do not cause decrease in the ocular perfusion pressure. And it is said that diastolic ocular perfusion should not be less than 55 millimeter mercury, which has been published and proven in almost 6 trials which have been done. So that is another important factor as told by Dr. Vinita ma'am. Yeah.
And any role of antioxidants or methylcobalamin preparations in?
Not much, sir. A lot of things have been tried, like citicolin, forskolin, so many drugs are there, but none of them have been proven in the published literature. They all are under trial stage, and when nothing works, you give something for your own satisfaction to these patients.
Exactly, I agree with you.
Yeah.
So, Dr. Bhalla, please go ahead.
I think it's working from there only, so I'll stand here and do. So I think these are topics. Should we treat glaucoma early, or we should treat glaucoma later on, wait for some time? So what I'm trying to emphasize is treat glaucoma early so that you prevent progression before it starts. We all know that open angle glaucoma is the most common cause of irreversible blindness, and some studies have shown that high risk of developing blindness, and many populations-based studies have shown that about 90% of persons identified as having glaucoma, they have not been diagnosed. So late diagnosis is a very strong risk factor for glaucoma blindness. What is the Indian scenario? 12 million people are affected, 1.2 million, that is almost 1/10 are blind from the disease, but the most unfortunate part is that more than 90% of these cases remain undiagnosed. So there are two trials which I'll touch upon to show that why early treatment is important. One is early management of glaucoma trial EMGT, and other is OHTS, which are hugely popular glaucoma trials. This was, EMGT trial was important randomized controlled multi-center trial, and it to demonstrate the benefit of IOP reduction in early diagnosis of glaucoma. And the trial consisted of 255 patients with early diagnosis glaucoma, which was randomized to treatment with trabeculoplasty and topical hypotensive versus another group which did not receive any treatment. So this was the randomization and two groups were there. And what are the results? At 6 years, 62% of untreated patients showed progression, whereas 45% of treated patients progressed. So, and the median time to progression was 66 months in treated versus 48 months in untreated group of patients. So this was the result, and it also showed that the risk of progression decreased by 10% per millimeter of mercury IOP drop from the baseline. And these are the baseline risk factors. If there is higher IOP on presentation, presence of pseudo-exfoliation, older age, lower systolic and diastolic perfusion pressure, lower central corneal thickness, and presence of disc hemorrhages. So what was the implication of EMGT studies? In eyes with glaucoma, IOP that was lowered by 25%, treatment was of benefit versus no treatment. And there is beneficial effect of immediate therapy to lower the IOP versus late or no treatment on the progression of newly detected glaucoma. So what we have learned from EMGT is even small reductions in intraocular pressure can make a difference. Every millimeter of IOP reduction was associated with risk reduction of 10 to 13% depending on the analysis. But that does not mean we take it blindly and start treating all patients, because we cannot know which patients will progress and which patients are to be observed closely. So it is, I'll just take a minute more. It is beneficial to lower pressure in patients progressing quickly, even if IOP levels have been in the range of 15 to 18 millimeter of mercury. Now I'll go to the OHTS trial. This was ocular hypertension treatment study. This was also a randomized trial where there was two groups, medication group and close observation group, and this was the study population, and these were how the patients were defined and distributed. And they found that in observation group, the IOP reduction was 4 plus 11.6%. In medication group, there was significant decrease in IOP to the extent of 22.5% plus minus 9.5%. And in observation group, the risk of developing primary open angle glaucoma was 9.5% compared to medication group, which had risk of developing glaucoma to 4.4%. So when the side effects were compared, there was no significant side effects. So what we learned from OHTS, I'll just hurriedly go through because there is sparsity of time. In there were OHTS 1, OHTS 2 study. In OHTS 1, 5 risk factors were identified, of which central corneal thickness was very important factor, besides family history, increased vertical CD ratio and pattern standard deviation. And in OHTS 2, it was found that there was reduction in incidence and delayed onset of POG with early treatment. So take home message from this is, OHTS is, early medical treatment of ocular hypertension reduces the 5-year incidence of POAG by 60%. Age, IOPs, thin central corneal thickness and vertical CD ratio and visual field pattern standard deviation are the 5 risk factors. Benefit of early treatment is greater in high risk OHT patients. Lower risk OHT patients can be followed without treatment. Assessing both structural and functional parameter in OHT patient is very essential. These are the ways to find which are the low risk OHT patients and high risk OHT patients. So in summary, what I'll say is it is better to start early treatment if patients have risk factors, as I mentioned. Even if IOP is in the lower teens, fast progressors, higher baseline intraocular pressure, lower ocular perfusion pressure, presence of pseudo-exfoliation, thinner cornea, and large vertical CD ratio, besides family history. So I rest my case here that early treatment is important if you have fast progressor and the patients with risk factors. With this, I also take the opportunity and request all of you for your kind candidate, for your support for my candidature for the post of Joint Secretary AIOS, which I am contesting, and the online elections, as you all know, start from 23rd February to 2nd of March. Thank you everyone for your kind and patient hearing.
Thank you, Dr. Bhalla. And now I invite Dr. Rashi Shyam to present her viewpoint.
So much has been said about EMGT and OHTS, and I'm going to defend the fact that not every high IOP needs treatment. So we will not be looking at the patient profile of the cases that were taken for the early manifest glaucoma. Early manifest glaucoma means it is a diagnosed case of glaucoma, and of course treatment has to be started. There is no question about it, whether early or borderline or somewhere more along the line. However, when we come to every high IOP, whether do we need to treat every high IOP or not? Sometimes watchful waiting works. So central corneal thickness and IOP is the first thing that I would like to bring your attention to. Central corneal thickness has a direct correlation to the measured IOP that we see in our OPDs. So it is mandatory if you see a patient with a slightly borderline or high IOP, please measure the central corneal thickness and use nomograms. There are many nomograms out there, and try to see what the corrected IOP is. Now there are 3 patient profiles that we see, and according to that we divide, of course taking the fact into account that gonioscopy shows open angles. You have primary open angle where the pressures are more than 22, there is demonstrable visual field loss, and you can see optic nerve head changes also. You have normal tension glaucoma where the IOP is less than 22, there is visual field loss, and there is disc cupping also. And then there is a third group which we label as the ocular hypertensive patients. There the pressures are more than 22, but there is no cupping, no visual field loss, and no other cause of secondary glaucoma noticed. So central corneal thickness becomes very important, and once we've done that, I would like to bring your attention to something which is a statistical value. It is called NNT, or it is numbers needed to treat. Now what is number needed to treat? It is a number which is epidemiologically calculated, and it is a measure of the healthcare indicating the number of patients that must receive a specific intervention. So here in this case we are talking about introducing anti-glaucoma medication. So there is a specific intervention, and we have to see the positive outcome versus the negative outcome. Suppose we withhold treatment, what will happen to the patient? So ocular hypertension treatment study very nicely followed many patients, and these were patients who had no demonstrable disease, but the endpoint was development of optic nerve head cupping with a visual field defect. Now, sir had shown a slide in which he showed that in the untreated group, the risk of progression to glaucoma was 9.5. And in the treated group, it came down to 4.4. So what we mostly read it as is that if we treat someone, we bring down the risk of the patient converting to glaucoma by 50%. Where does this 50% come from? It is 4.4 out of 9.5. But the other thing is now we need to look more closely, and we need to see what is the number needed to treat in this patient population. And when that is calculated, we see that to prevent one person from converting to glaucoma, you must treat at least 20 patients who will remain as they are, whether you treat them or not. Now the statistics don't look as good. So in the Indian scenario, we have the cost of medication, we have accessibility to procuring the medication, we have the effect of quality of life on the patient. The patient has to remember to put drops, carry drops wherever he goes. The physical appearance of the eye starts changing because of ocular surface disorders. There is periorbital fat atrophy, there are dry eye symptoms. Other side effect profile of anti-glaucoma medications are there, which pretty much goes unmonitored in rural population. Things like beta blockers with cardiac problems, asthma, and other things, drowsiness, and sometimes psychosis even. So psychological impact of being labeled as having glaucoma is also very big. The patient is always worried that he can go blind because there is so much information relating to glaucoma-related blindness out there. So it is very important that we decide which patients of ocular hypertension actually need treatment. As Dr. Bhalla said, these should be patients who fall in the high-risk group, those who have family history and other things. And then once we are not treating, we should give rigorous counseling for the strict follow-up of these patients so that we are monitoring them down the years. And we should choose the patient profile also if we are abstaining from treatment. And I think watchful waiting does work. In my personal experience, I have many, many young patients who have pressures between 26 and 28. They are on no medication. I have personally followed them for 10 to 15 years without any change in the field or the optic nerve head. So I rest my case with that. Thank you.
Thank you, Rashi, for wonderful presentation. As by definition, ocular hypertension is a raised intraocular pressure and no glaucoma damage. So our methodology for checking the intraocular pressure should be accurate. What we as a glaucoma expert is talking about the applanation tonometry, and that applanation tonometry also to be repeated to confirm that exactly the pressures are beyond 21 millimeters of mercury. In my personal practice, between 21 to 25, I don't treat. I just observe. Between 25 to 30 millimeters of mercury, I always do the gonioscopy to confirm, and I always do the diurnal that I am not crossing that range. So between 25 to 30, I will treat only if the patient is at high risk. Suppose the patient has a thin cornea, patient is one-eyed, patient has a family history of glaucoma, the patient is coming from very far off, he will not come for follow-up. And above 30, definitely you have to treat. So that's the usual protocol I follow in my clinical practice.
There is one very common problem in general ophthalmic practice. Suppose some patient is coming to you and somebody has started anti-glaucoma medication, it's very difficult to discontinue that. Even if you tell them, the patient will say, "नहीं, उन्होंने मना किया था कि कभी छोड़ना नहीं है." Secondly, I have seen in my practice also, the patient was not properly investigated, and just because the patient was having tension of 20, 21 or 22, he has been started. So I think before starting the treatment, we must establish the diagnosis. That is very important, because once you start the treatment, the cost of treatment is there, then the quality of life. There are so many factors, what Dr. Rashi has rightly pointed out. So
I think glaucoma is both underdiagnosed and overtreated. One, diagnosis is missed, and there are patients who do not have glaucoma and they are treated just on the basis of intraocular pressure. They don't have any significant cupping, they don't have visual field defect. Even if you do OCT, RNFL and GCC, do not find any perimetric or pre-perimetric changes in their investigation. Like Dr. Vinita said, pressure less than 25 can be kept under follow-up. Any pressure above 28 millimeter mercury, irrespective of absence of visual field changes, should be treated, for the reason that this patient may not only develop glaucoma, there are chances of development of venous occlusion also. So any pressure of above 28, I make it a routine to treat, whether they have perimetric changes or OCT changes or not. Yeah.
I think the next topic is early lens extraction versus peripheral iridotomy. So again, Dr. Rashi is there, and Dr. Nilesh is also there. Dr. Nilesh, yes. So I invite Dr. Rashi Shyam.
Till she gives her
And
presentation, she wanted to
Dr.
add
Poonam wanted to.
wash-up period of that drug is over, suppose whatever drug 7 to 14 days is a wash-up period, you call that patient and notice the highest intraocular pressure. Then call at the some different timings and again note the highest intraocular pressure. So now you know that the patient is within the range of say 20 to 25. So then you call every yearly for a checkup. But if it is more than 25, then every 3 months you have to call.
Dr. Ashi.
The second topic that I have to present on is clear the lens early for long-term IOP control, and then the IOP control is much superior. Before I start, I want to clearly state that we are talking about clear lens extraction. In primary angle closure glaucoma, if there is a cataract, it makes sense to do the cataract surgery with an IOL implantation. But here we are talking whether clear lens extraction in such patients should be done or not as part of management of glaucoma. So the hypothesis is that in Asian populations, we have more of primary angle closure glaucomas, and the lens thickness has a mechanistic role in the evolution of glaucoma. There is an increase in thickness of the crystalline lens as it ages, and primary angle closure glaucoma is known to have a very rapid progression with higher IOP range. So we will see patients who are almost having glaucomatous optic atrophy in one eye and maybe a normal normal optic nerve head in the other. Now, till now, the traditional management has been laser peripheral iridotomy with or without topical medications. This is a chart which shows how the lens thickness increases with age, and as the lens thickness ages, the anterior chamber depth also changes. There is not just a change, the lens is actually thickening at the expense of the anterior chamber depth. There is a shallowing, narrowing of the angle, almost 0.5 millimeter narrowing in 50 years. And after cataract surgery also, now that we have OCT, it has been documented that the anterior chamber depth and the anterior chamber angle values all show much better numerical values as far as glaucoma is concerned. The pressure, average pressure too, also shows a decrease of 3.2 millimeter of mercury. So EAGLE study was done, and this was the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma. Now this was a multi-center study, and as we can see, the population varies from Caucasian to Mongoloid race to mixed kind of population in these countries. And these were all phakic patients, more than 50 years, with an IOP of 30 millimeter and a gonioscopy showing primary angle closure glaucoma. Now the two groups were randomized into clear lens extraction group and other group where iridotomy was done with topical anti-glaucoma medication. What was studied, how much of an IOP difference there was, the health benefits of doing a primary procedure, and the cost effectiveness. Now 419 patients made it up through the follow-up period, and there was robust evidence that showed that IOB control is much better where clear lens extraction is done versus the other group. Now what are the advantages of clear lens extraction? We have hypermetrop patients, so it corrects the refraction, first of all. Second, this one single procedure brings down the need for anti-glaucoma medication and the risk of progressing to chronic angle closure glaucoma or having angle closure glaucoma attacks. It is cost effective, even though it is a surgical procedure. When you compare it with what the patient has to invest in medications and then increased need of medication over the coming years. So it is seen that by 3-year period, surgical procedure is more cost effective. In the Western world, this is very important as far as insurance goes. But apart from that also, it has much better quality of life. Patient is seeing better. He is more relaxed because he feels that now angle closure is not going to happen to me. He's not using medication, so there are reduced side effects and better quality of life. And subsequent interventions which are required with PI also. Now we have seen that when we do PI in patient, that is not the end of the story. After PI, some patients need 1 medication, it goes on to 2 medication, 3 medication. That does not work, you have to do a TRAB. Ultimately, if cataract starts developing, you have to do a cataract extraction. So the number of interventions the patient has to face is also much more in the second group. So this is a one-time procedure with a reduced risk of non-compliance to medications and with very reduced risk of progression to severe form of disease. So this was a breakthrough, and what most, how does it apply to the Indian scenario? In Indian scenario, the iris is thick, more hypermetropic eyes are there. Laser PI has its own complications and difficulties. The only drawback of this procedure, clear lens extraction in younger patient group, is that there is a loss of accommodation. So if the patient is not already presbyopic and we do a cataract, he will need glasses for near. So nowadays when cataract is being done for so many other indications, cosmesis, phakic lenses, accommodative lenses, patient complains of glare, difficulty in driving, he gets operated, patient's vision drops to 6/9, 6/12, he's not happy with his vision, he wants to get operated. I think to prevent glaucoma in primary angle closure glaucoma, It is a paradigm shift, and surgeons should start thinking as a therapy, because glaucoma per se is a much more dangerous disease, and lens extraction as a proven way of controlling glaucoma in such patients should definitely be considered by all surgeons who can do a good cataract surgery. Thank you.
And Dr. Rashi, you rightly pointed out that you have to think 10 times before going for this procedure, especially in young patients, because the loss of accommodation, that is very important.
Sir, actually, Eagle study also concentrated on patients who were above 50 years. It was not taking into account patients with clear lens in the younger age group.
So, thank you. And now I invite Dr. Nilesh Kumar.
So I would like to ask Verita ma'am, how many of the patients you abandoned PI because Indian patient had thick iris? None. So that argument remains moot. That thickness doesn't matter. So this is something you have to kill. This is my humble suggestion that laser PI is still better, and we should not go for overkill. Like if you have to kill a fly, you can kill with a swat, not use hammer, because it will cause more damage than that. So just before 2016, when Eagle had not landed, lens was sacrosanct. You can't touch the lens for treating glaucoma, but suddenly in 2016, based on only 419 patients, and the IOP, long-term IOP reduction of 1.18 mm Hg that it was giving, which you can easily gain if you skip caffeine. If you don't drink coffee, you will get that much reduction in IOP. So shall we sacrifice coffee or shall we sacrifice the lens? That is the question that we need to answer. The Eagle study at 3 years of follow-up, more than 50% of the patients were not having gonioscopy data. So it doesn't prove that the angle has actually opened. It is just assuming that the angle has been opened. So it is not actually proving what it is. And as ma'am told, it has to be done by expert surgeon. And in the expert surgeon also, during the Eagle surgeon, they had posterior capsular rupture, vitreous loss, iris prolapse, and aqueous misdirection. Now what will happen if the novice starts to do it? And most of all, what ma'am showed very clearly in the heading is it was meant for PACG and not PACS. And we are combining both of them. The thing that was supposed to be for PACG, we are implying on PACS and saying that we should do it. We should not do it. It is PACS. For the suspects, we need to do minimal invasion and not the maximum that is possible. Again, the price, the laser PI cost cannot be compared with CLE. However, cost effectiveness at long term, you can see it is not going to be equal. It is very crucial. And the ZAP trial that was published in 2019, and you see it is 889 bilateral PACS patient in real world, and there is a reduction of 50% of IOP. So 1.18 versus 50% of reduction, you can see how effective it is. So effectiveness is not a problem. Ma'am told in her previous talk that NNT is very good indicator if we look for epidemiology, and there is no NNT data for Eagle study, but for ZAP study, the NNT at 6 years was 44 and NNT at 14 years is 12. So it proves that it is going to, the 5-minute procedure without, it's minimal risk that is involved in that. It is giving 70% protection over 1.5 decades. Again, Singapore asymmetric narrow angle iridotomy study, that is analyst study, also says the same thing, that the risk becomes half over 5 years. Again, the corneal compromise has not been studied, but we all know that phacoemulsification leads to loss of endothelial cell, whether laser PI, if done right, is not going to touch the iris at all. Accommodation, as everybody has pointed out, it is one of the major factors that is there. So, during the acute attacks, even we can't do surgery. During the acute attack, we only have to lower that IOP and then do a PI and then move ahead with anything else. So a laser PI anyway forms the basis of anything that we do during acute attack of PACG as well. So let's always follow the stepwise protocol. What we see, it's LPI we should do, low risk, high reward, 70% reduction, and then if it is not there, we can go for medical therapy. And if the patient is showing signs of cataract, go for lens extraction. At least you can justify that there is some cataract and I am removing that, not losing it. So this is the scorecard. As you can see, the Eagle has a high cost, more risk, and less benefit compared to any of the LPI study that is there. So please keep the lens and trust the laser. Thank you.
Thank you, Dr. Nilesh. Wonderful presentation, and I consider that's a very good debate. The debate should be like this only. Both the presenters, they did justice to their topic. Dr. Rashi presented like a clear lens extraction. That is one of the method which was there, but I think in the practice we never use this thing. Dr. Nilesh has done a justice to his topic of doing a LPI, and he stressed and compared that how efficient is doing an LPI. So there is a concluding remark that yes, we should do LPI and clear lens extraction should be avoided. That is not the way to go, especially in PSC cases. And if it is PSCG, definitely if you do a lens extraction, probably you may not control the glaucoma and the patient will be in a false sense of security that they have undergone a surgery and they may not come for the follow-up of glaucoma. So PSEG patients are the one which progresses very fast. So we need to keep them under regular follow-up. So that's the best debate till now I have heard. Thank you so much to both the presenters.
And now there is the topic primary trabeculectomy versus tube shunts in secondary glaucoma. Dr. Seema Kumari, may I invite Dr. Seema Kumari? And Dr. Tanisha Oza is there? Oh yes, thank you.
A very good evening to one and all. I'll go with primary trab as it still has many edges. It still has an edge in many scenarios. So surgery in secondary glaucomas is basically preferred because of the outflow obstruction, the trabecular meshwork due to trabecular meshwork inflammation, or the structural changes like peripheral anterior synechia or secondary angle glaucoma, or due to steroid-induced IOP elevations. Now, reasons to choose trab are, whenever you are opting for very low IOP targets, so as in cases of advanced optic nerve damage, you can go for trab. Or in cases of uncontrolled IOP on maximum medications, or if there is medication intolerance or severe allergy or persistent non-adherence. And marked IOP elevations are there in the fellow eye. Now, the PTVST study, that is the primary tube versus trabeculectomy study, it was designed to answer one very quick, crucial question, and that was that should the tube shunts replace trabeculectomy as a primary glaucoma surgery. Now, and it inferred that trabeculectomy generally offers superior low pressures, while the GDDs have a very better safety profile regarding the early post-operative complications. But as both progress to cataract, it is always ideal to go for combined procedure, that is a cataract surgery with a trabeculectomy. Now, in cases of neovascular glaucomas, trabeculectomy yields a superior visual outcome, but it carries a very high risk of post-operative inflammations, complications. But if trabeculectomy is assisted with adjuncts like MMC, it can be a viable option when the neovascular activity has been regressed with anti-VEGFs and PRP. In cases of uveitic glaucomas, trab plus MMC, it effectively reduces the IOP, and that occurs when there is sufficient inflammation suppression by the medical management. However, there has been studies and they have showed that there were significant differences in their safety profile, like CME and revisions were more common and higher in GDDs, and the cataract progression was higher in trabeculectomy. Now, trabeculectomy with MMC is a reasonable surgical option when primary GDD failure occurs. Post-traumatic angle recession glaucomas, if you see, it is a risk factor for the failure of trabeculectomy, but when supported by the use of anti-metabolite therapies, it can actively suppress the fibrosis after trabeculectomy in these participants, so then it can be a good viable option.
In pseudoexfoliation glaucomas, trabeculectomies, they significantly reduce the IOPs. However, they have a lot, if you compare the short-term surgical success with the long-term surgical success, then the short-term surgical success is much more than the long-term surgical success. So on the basis of evidence-based studies, we see that the overall success rate of trabeculectomy is 81.8% as compared to 81.3%. And trabeculectomy patients, they require significantly fewer mean medications after 1 year compared to the amida valve patients. And in the trabeculectomy showed a higher success, complete success rate, while the amida valve procedures, they have shown a much higher qualified success rate, meaning that the patients, they need more additional medications for the IOP control. And there was a significant reduction in the medication burden favoring the trabeculectomy procedure. So we can conclude that trabeculectomy yields superior vision outcomes, but it carries a very high risk of post-operative complications, which emphasizes the importance to customize the treatment selection and give a very vigilant post-operative care. And trabeculectomy is a very cost-effective procedure, and it can cater to very population with low socioeconomic backgrounds. Moreover, trabeculectomy has a very good advantage that it can be modified with a number of, and adjuncted with a number of modifications, and that can be suitable for many of the secondary glaucoma procedures. Thank you.
Now can I invite the next Dr. Tanisha Oja.
Good evening, everyone. Thank you for this opportunity. I'll be speaking for tubes. Tubes are tougher, reliable, and repeatable in complex cases. So while they are connecting, I'll go on speaking. So there's a myriad of tubes available which can be chosen from, and especially in hostile eyes where tubes function independent of the conjunctival health, whereas trabeculectomy is highly vulnerable to scarring, inflammation, any prior surgery, and exposure to the drugs. Tubes bypass the wound healing battlefield. So among the high-risk scenario cases where trabeculectomy underperforms, tubes excel. Will you be able to connect my slides now, please? No. Should I continue? There's a problem with the connector they have. Okay, no problem. Okay. Yeah. Right. Yeah. So in cases like neovascular glaucoma, uveitic glaucoma, post-vitrectomy eyes, aphakic eyes, failed prior filtration surgeries, and cases like pediatric and traumatic glaucomas, tubes are less dependent on the etiology and tubes excel. So the evidence gathered from the trab versus tube study, the key takeaways were lower failure rates with tubes compared to trabeculectomy with MMC, fewer early postoperative hypertony related complications were noted with tubes, and able to connect. Sorry for the interruption. So I was talking about the tube versus trab study and the key takeaways that we had. So comparable IOP control could be achieved with the two methods, but in the long-term cumulative failure rate which was noted was very high in the trabeculectomy group compared to the tube group. So tubes offer survivorship advantage. Also, Dr. Seema was talking about the primary TVT study, and there also the effectiveness was higher in the trabeculectomy group in regards to the early IOP control, but the long-term follow-up is still stated that the tubes had much less failure rate and much less number of repeated revision surgeries. So the results of the TVT study provided further support for the expanded use of tube shunts beyond the refractory glaucomas, although these devices have been historically reserved for surgically managing glaucomas at high risk, but in this study they enrolled cases with lower risk as well. So in trabeculectomy, even with the metamycin C and other wound modulating agents, there has been early bleb failure, late bleb leaks, and bleb related infections. So successful trab also has to be nurtured and taken care of, like taking care of the bleb, managing with 5FU, and a lot of follow-ups are required. Given the strategic advantage of tube, it allows a lot of surgical flexibility, like a second tube in different quadrant, a tube revision surgery like a tube extension or tube shortening, and also cyclodestructive procedures can be used as an adjunct. So there's lower dependency on the follow-up care. Trabeculectomy requires frequent visits like suture lysis, needling, antimetabolite injections, whereas tubes provide very structured healing and tubes suit the real-world follow-up constraints. It has also been noted that fewer sight-threatening complications happen with tube, and the tubes usually are preceded by signs of exposure. But the bleb-related endophthalmitis can be sudden and vision-threatening, so the tubes shift the risk from catastrophic to manageable. It also gives surgical standardization and reproducibility, and tubes are more like device-driven and less dependent on the micro technique of the surgeon. So in the complex case scenarios which we are facing in the modern glaucoma reality, with the aging population and the pseudophakic dominance, secondary glaucomas on the rise, and there are multiple prior ocular interventions that the patients have undergone. So the primary trab is actually not a primary trab or a primary procedure on an untouched eye. I would also like to point out on the future trends or the ongoing trials where newly designed glaucoma drainage devices can be adjusted post-operatively to reduce the incidence of hypertonia and hypertension, and these devices can be controlled from outside with a gauge. So to conclude, trabeculectomy fights biology, whereas tube shunts tend to work around it. So in today's complex glaucomas, reliability beats idealism, and tubes are tougher, repeatable, and more dependable. Thank you.
Again, the question comes, what about the learning curve? Because trabeculectomy has been since long.
Certainly.
So, yeah.
So the tubes definitely have a longer learning curve, and also tube exposure and other things are also a concern. But in cases where, like I said, in the hostile and cases which are predisposed to having a failed trab, in those cases, a primary tube surgery can be taken up, like in neovascular glaucoma, where we know that the fibrosis is on the go, and it might occlude the bleb, and a non-functioning bleb can happen very early. So that is expected in certain eyes. In those cases, a primary tube can be considered.
And what about cost effectiveness?
Certainly, sir. I was supposed to speak for tubes, so I was speaking for tubes. But when it comes to cost, definitely trabeculectomy is much better.
So with this, we come to the end of session, and now I request Dr. Vinita to sum up the session.
I think that was a wonderful debate we all discussed, and the glaucoma we can keep on discussing because there are various permittable combinations, low intraocular pressure, very high intraocular pressure, the non-progressors, the progressors, and this is one disease where we write suspect. So that also we need to keep under our minds when we treat. It is a lifelong disease. So not be in a hurry to diagnose the glaucoma or tell the patient that you are having a glaucoma, because it carries a lot of psychological impact. I have seen young boys being told that you have a glaucoma, and then when they go and read on internet that they will become blind, so they go under stress. So carrying a psychological stress is more dangerous rather than carrying a deep physiological cup. So we have to be very careful. There is no hurry in diagnosing the disease. It is not progressing in a day or two. You confirm your diagnosis and tell the patient. Thank you so much for the patients listening.
Thank you. Over to the hall coordinator. Thank you. May I invite all the speakers to the dais? All the speakers. Poonam, Rashi, all the speakers, please come to the dais for a group. Nilesh. अच्छा आ जाओ आगे ही आ जाओ.
डॉक्टर मयूरी भट्टाचार्य जी बाद में. डॉक्टर विभूति कश्यप, डॉक्टर विभूति कश्यप, विवेक मिश्रा, डॉक्टर विवेक मिश्रा, डॉक्टर विवेक मिश्रा प्लीज. स्पीकर में नहीं request Dr. Jharkhand to come on the stage, please, to give her the mementos. Dr. B.N. Gupta, Dr. Mayuri Bhattacharya, Dr. Vibhuti Kashyap, Dr. Vivek Misra, and of course myself.
अभी इसका हो गया नहीं हो गया ना. For the next awards, that is JHOS Excellence Award, may I हो गया ना, हो रहा ये करना है. For JHOS Excellence Award, Dr. Anindya Anuradha, Dr. Vibhuti Bhushan and Dr. Ajay Gupta. If you are here, you will get it. If you are not here, you will not get it. It will not be handed over to anybody else. So please make sure that you are here. Dr. Ajay Gupta, Dr. Vibhuti Bhushan and Dr. Anindya Anuradha. Dr. Ajay is here.
Dr. Ajay is here.
Dr. Vibhuti Bhushan. अच्छा अभी यहाँ पर good, good. So our President, Dr. Jharkhand Agarwal, is requested to hand over the JHOS Excellence Award to Dr. Ajay Gupta. A photo भी हो जाए Ajay Gupta. अरे वहाँ they will bring it now. So first award is for Dr. Ajay Gupta.
JHOS Excellence Award. Okay. Next is for Dr. Vibhuti Bhushan. Thank you, President. Anindya Radha, probably she is not around.
Dr. Poonam.
Dr. Poonam, as a speaker, have you received the memento?
नहीं मिला
राशि शाम को ये मिल गया. It's all done. Thank you so much. Huh? They have all got it. Okay. Prema, anything else that is left?
Sir, please. एक बार आ जाइए.
ठीक है बात क्या ले रहा है फैकल्टी वाला
The Chairperson Award for Dr. B.N. Gupta. I request our President to kindly hand over the memento to Dr. B.N. Gupta. Present President to the past President. So, this is the end of the session and we'll proceed for the general body meeting.
So I request all the JHOS members to be here for the general body meeting.